Hi, I'm David Freudberg. We here at Humankind are trying to strike a balance to make our public radio programs available to you and also to make sure we're able to pay our production costs, from office rent to staff time to studio and distribution expenses. The grants we receive from funders you hear named on our programs don't fully cover our operating costs. And if you like what you hear, we're asking for your help so we can keep our program and this podcast going. Please visit humanmedia.org, and at the top of our homepage, click on How You Can Help. Thanks. Humankind is produced in association with WGBH Boston and supported by the Humankind Program Fund.
These priorities can be pretty harsh to determine. To have to forego, important medication because you got to get food.
Has that ever happened to you?
Yes.
At a time of extreme income inequality, we also face health inequality. You're listening to a Humankind special. I'm David Freudberg. I set off on this program seeking answers to a simple but troubling question. Why does poverty tend to shorten a person's lifespan? Public health studies show that the wealthiest Americans live 10 to 15 years longer than those with least income. And the consequences are being felt at this time of drastic income inequality, a level not experienced since Americans first heard the bluesy tunes of the Jazz Age in the 1920s, a period that led to the Great Depression.
Not since those bygone days of old Joan, I ever person had such luck as mine. Seems that I was born just for sorrow, and the sun on me won't shine.
The effects of health inequality take many forms, some disturbing. Hospital emergency rooms report higher rates of illness and injury for people of low income. And there's little question that trouble paying for medications or just paying for your next meal can take a toll on a person's well-being. I talked with patrons of a food pantry here on the North Shore of Massachusetts in the storied fishing town of Gloucester. Here's Carolyn Curley.
My medications are so high, it's pathetic.
What do you need medications for?
Like a hyper medicine?
Heartburn medicine?
Yeah. And then I have for your high blood pressure and things like that. And combine them sometimes. I don't have enough money to pay for my meds to keep going,
So what happens on months when you can't afford the meds?
I don't get them. I just skip them. I don't bother getting them. I don't bother taking them.
Is there a noticeable result if you can't get your blood pressure med?
Yeah, my blood pressure goes right to the moon. Like one time it was over 255 over 84.
Wow.
And I went up to the hospital.
Yeah, you could get a stroke from that.
Yeah. Unfortunately, I didn't get a stroke, thank God. I have sleep apnea. I have high blood pressure. I'm overweight, as you can see. It's a lot of things.
And this is Massachusetts, a state that led the country in making strides toward universal health care. Here's Doug Goldman, another patron at the pantry. What age were you diagnosed with diabetes?
34.
And you're how old now?
61. Now, I've been insulin dependent for 20 years.
Yeah. Is it hard to manage all that?
Yeah, extremely hard. Some people are really disciplined that way. Right now, I'm on a roll. I'm losing weight. I have this and that going on. I have to have a knee replacement.
Doug has held a variety of jobs, from selling musical instruments to working in the fish department at a local supermarket. At times, he's faced the kinds of choices people make between paying for medicine and other necessities.
These trade-offs are, you don't want to make them. But every, indigent people have to. And there's a lot of that in this country.
Do you regard yourself as indigent?
I live below the poverty level, but no, I don't regard myself really as indigent. I'm okay.
Nationwide, even with more people covered through the Affordable Care Act, nearly 30 million Americans remain without health care. This is Bellevue Hospital in New York City, founded in the 1730s. It's America's oldest public hospital, part of a system called NYC Health and Hospitals, the largest public health care system in the United States. They log in more than 1 million patient visits each year, mostly with people of low income. Physician Dave Chokshi leads the system and sees individual patients 2 days a week. Recently, he's been caring for a patient who had suffered a stroke.
She actually woke up one morning and she found that the room was spinning. She actually couldn't articulate the words to describe the symptoms she was experiencing to her husband because of the stroke. And so she was brought into the hospital at that point, and she received very good care and actually is making a very good recovery. But she had undiagnosed high blood pressure, which was likely the major contributor to having the stroke in the first place.
And it's not unusual for a serious medical condition to go undiagnosed. People may avoid doctors to avoid medical bills, or because getting to the clinic may be complicated if you don't have transportation.
She is someone who had immigrated into the United States about 15 years ago, had not seen a physician during that period of time, and had one of the most common medical conditions that exists that could have been treated differently. So I think a lot about those illness trajectories where a different outcome or a preventable outcome could have been reached.
One of the things I have found startling is evidence that children born into poverty tend to have lower birth weights than children born into higher income families. Can you explain why that would be?
Mm-hmm. There are many reasons, but it gets to the idea that the way that poverty and health interacts is not just in one person. It can actually be intergenerational, from a mother to a child, from one family member to another. And so the example of low birth weight shows that for a multiplicity of reasons, again, it could be that the mother didn't have sufficient nutrition during their pregnancy. It could be that they were exposed to toxins, cigarette smoke, other substances that could contribute to low birth weight.
Jacob Bohr of the Boston University School of Public Health.
Following the 9/11 terrorist attacks, babies born to Muslim women were of lower birth weight because of the increased stress that their mothers faced in this atmosphere of Islamophobia in the wake of the terrorist attacks. Similarly, there was lower birth weights were observed among Hispanic women in Iowa following immigration raids there, and those are specific examples where low-income Americans face larger stressors.
So for multiple reasons, from food insecurity to struggling to pay the rent and utilities to social prejudice, living in poverty can contribute to tense, frustrating conditions. Dr. Dave Chokshi.
And we're increasingly uncovering that there are mechanisms by which chronic stress can also lead to poor health outcomes, not just for individuals, but across a life cycle and intergenerationally as well.
There is a phenomenon sometimes referred to as toxic stress, which in turn can actually lead to greater inflammation in our bodies, causing an increased risk of heart attack and stroke. Can you help us understand how that works and what it means?
The science of this is still being unearthed, and we are trying to understand the precise mechanisms by which toxic stress leads to adverse health outcomes. But the association is very clear. Toxic stress is the idea that the stress that any of us experience on a day-to-day basis occurs so repetitively and to a certain magnitude that it sort of adds up in a cumulative way that leads to illness and poor health for the person who is experiencing it.
We all know we make different choices when we're stressed.
Lauren Taylor is co-author of The American Healthcare Paradox, which examines why the U.S. spends so much on medical costs, including when the stresses of daily life kind of get under our skin and can lead to health consequences.
We make choices to stress eat, or we make choices to skip things that are important, meetings or doctor's appointments or what have you. Or you're stressed and you forget to do things. You forget to pay the rent on time, or you forget to call the babysitter. And so, stress can have all sorts of impacts on health that are not necessarily under the skin, but are just behavioral.
Stress is something that everyone can understand because we've all experienced it.
Dr. Dave Chokshi of New York City Health and Hospitals.
It's, that feeling of your heart pounding. It's insomnia because something is gnawing away at you from the inside. It's headaches, that you can't explain by any biological phenomenon, but things have been tough at work or in your family. And all of those are things that if you have enough resources, both material as well as social, you figure out ways to cope with those things on a day-to-day basis. But it's not such a stretch. We don't have to use our imagination so much to think that what if I were experiencing those things relentlessly every single day? How would that change my body and my mind? And that's what a lot of people who are living on the margins, whether because they're poor or for other reasons, experience every day.
People handle the strain of living on the margins in different ways, and not necessarily in healthful ways. The Centers for Disease Control and Prevention report that individuals living below the poverty level have higher rates of cigarette smoking than the general population. Boston University's Jacob Bohr.
I think both tobacco and other substances, including alcohol and including opioids, to some extent serve as coping mechanisms to deal with the stresses that people face in their lives. So I think that's one partial explanation for why in the last 40 years you've seen such a divergence in terms of smoking rates between richer and poorer Americans. And why with the opioid epidemic, which surely affects all strata of society, but is disproportionately affecting lower income people.
Several studies have shown that low-income youth and adults are disproportionately targeted by fast food advertising. This tends to promote obesity and other negative outcomes. So people who are struggling to make ends meet may be powerfully tempted into making choices that harm their health. Dr. Dave Chokshi.
Part of the reason is that when you have a limited income, when you just don't have very many means, you will try to stretch that dollar as far as it will go. And the way that our food system in the United States, at least, has been set up, the cheapest foods are often the least healthy foods. We know that processed foods are not healthy, but they're mass-produced. And they're mass-produced in a way that you can get a lot of calories from a small package. And so from the simple economic perspective, that idea that you get a lot of empty calories for little money is contributing to what we're seeing in terms of overweight and obesity.
People can be obese and undernourished at the same time. And I think that can be a real eye-opener for people.
Lauren Taylor.
You can consume empty calories. You can not get the right micronutrients. You cannot be taking in food at regular intervals. And so then when you do sit down in front of a big pile of food, you overeat because you just have this instinct that you don't know where your next meal is going to come from. And so let's load up now because who knows when it's coming. And so, it's a lot of the things we've talked about in terms of environmental factors that I think contribute to rates of obesity that we see in low-income folks. It's about, is your neighborhood safe to exercise? I have the luxury of being able to go out for a run more or less whenever I want to. If I thought there was active gang violence in my neighborhood, would I feel as comfortable going out for a run? Probably not, and especially maybe not at 9 or 10 o'clock when I get home from my second or third job. Access to food, if I live in a place that is sometimes called a food desert, those are places that don't have usually supermarkets or places with fresh produce, then, where am I supposed to get the kinds of food that would give me the micronutrient profile that I'm supposed to get and that would keep me feeling full and satiated so I don't go to that vending machine or I don't reach for, whatever the kind of junk food is that next comes into my path.
We're examining how living in poverty can be harmful for your health. You're listening to Humankind. I'm David Freudberg. For more information on this segment, Part 1 of Health Inequality, and to obtain audio downloads or CD, please visit humanmedia.org. Back now to the food pantry in Gloucester, Massachusetts, regularly patronized by people of low income.
For a long time, I tried to get this green card thing and try to get health insurance, but everywhere I turned, I was running into a block wall.
This is Dale Harris, originally from Barbados in the West Indies. He says he works part-time and has lived in the United States most of his life, but has problems with his green card registration, which limit his access to some public services.
I've been here since the age of 12, so, I pay taxes and everything, and this is the treatment that I get, and after a while, that gets irritating after a while. It does things to a person's well-being, to their thinking and their judgment. So you got to be very careful. You have to have a whole lot of patience, to go through this.
Well, I'm sure that's certainly true. So are you saying that it can be stressful for you?
Yes. At times, especially everywhere you turn, people tell you to go do this way, go here, go there, and every time you do that, there's a block wall that's stopping you, just because of a couple of numbers, So.
Numbers on a green card, for example?
Yes, exactly. That's what I'm talking about. Yes. I've got the numbers, but they just want the proof, because of all this stuff that's going on with the borders and stuff like that. I don't blame them, but some of us have been here for their whole lives, and we should be allowed, to have access to a lot of stuff. We don't get nothing,
And it's not just frustrations with the bureaucracy. Dale's ability to afford medicine is also on the line. When we met, he was up against several serious health problems.
For a long time, I didn't have access to any of my medication and stuff because I didn't have the insurance, and then I went to try to get it by paying cash for it, and that's outrageous, because for a month's supply of one medicine that I have, it's over $200. It's $240-something just for 90 pills. Like how is that going to work? So I have to pick and choose every month, what do I pay or whatever, because I have high blood pressure too, and I have to have that medicine, so every day. So, and that's where I've been for a long time, stuck like that.
Have there ever been times when you just skipped the meds because it was too expensive?
Yes. I skipped the meds for a long time, for years, because I couldn't afford it, so, and I was lucky by the grace of God, that I didn't drop dead because of it, So I had to be very careful what I do and how I reacted. Keep my stress level down. That way my blood pressure don't come flying through the roof, So.
What do you do to keep your stress level down?
I just try to stay as calm as possible. And try not to let anything get to me too bad, If that do happen, I just hit the door and go outside for an hour or two, and just just go down by the water and just hang out, you know.
Well, you live here by the ocean, so that can be very therapeutic.
Yes. That's the benefit in itself right there, you know, because we live by the ocean. We've got the $1 million view every time I get up, you know.
$1 million view. Well, the Gloucester and Rockport have those, don't they?
Yes, they do.
Well, here,
all over, you know.
here on Cape Ann. Medical professionals are increasingly aware of the importance to our health of the lifestyle choices we make. Our attention to diet, to exercise, and to stress management, self-care are areas where individuals have some personal choice. But for healthcare givers, supporting healthful choices can be a matter of careful timing. Physician Dave Chokshi at Bellevue Hospital in New York.
The patient I was seeing last week, who I just remember very vividly, this is a patient who had recently been hospitalized with a very serious infection. She had an amputation within the last year. You know, it was related to her smoking. And so top of my problem list was helping her to quit smoking. For her, she was so clearly concerned about her son, who lives outside of the United States, who is suffering with health issues of his own. And she wanted to tell me about those health problems, and she wanted to talk through them with someone. And this was so clearly a source of distress for her, and something that, I had to kind of shelve my agenda so that I could bear witness to what she was most concerned about.
What a powerful insight to bear witness, which may or may not also be accompanied by advising the patient. But you play a role in that context in merely honoring the human dilemma?
That's right. And it's, it's, of course, an extraordinary privilege to get the windows into people's lives that we do as clinicians. But I find that bearing witness will have a tangible impact for the patient as well, in the sense that it allows us to talk as two humans, for me to gain some insight into what her values are and what is top of mind for how she thinks about how she's going to organize her time and her life. And it's just a more realistic way for me to think about what it is that I can offer to support her in navigating the journey, to improve her own health. And we didn't get to talking about smoking cessation during that appointment. We might not get to it at the next appointment either. But I think particularly as I've gained more experience as a clinician, you learn that that's okay. And these are the small, seemingly intangible ways in which you foster trust with people, who will then endow you with the chance to walk with them in whatever it is that they want to do to improve their own health. And so I think it's far more likely in the medium to long term that she and I will have a conversation about her smoking in a way that is resonant with her and where she will perhaps take me more seriously than another clinician in the past, because I've been shoulder to shoulder with her in these other struggles in her life.
As we've discussed, it's hard contending with health challenges amid financial hardship. Rob Lawrence, himself a Gloucester healthcare worker, faced this dilemma in his family.
My older sister, 5 years older, her name was Mel. Mel had diabetes, and as time went on, she lost 2 legs to diabetes. She lived in Louisville, Kentucky. And she would call me all stressed out, sometimes crying on the phone about the medical care, not getting appropriate medical care from hospitals and doctors.
Although surrounded by loved ones, Rob's sister had a hard life in her final years, a fact that was difficult for Rob to bear from a distance.
She suffered, and the church would help, and friends and family would help her pay for the things she needed. And then unfortunately she got cancer, and that just made things worse. And she died 6 years ago from the cancer. But in her fight, she always kept a positive attitude, and she had a strong belief in God. But I was shocked at the thousands and thousands of dollars and the costs that they expected a disabled person to pay.
This is the stark reality faced by so many Americans, given the current limitations of our system of healthcare financing. The kind of wrenching dilemmas that have roiled our national debates over who gets medical care and who pays.
I do remember she needed $800 before one doctor she needed to see would see her. And I remember I sent her a couple hundred, and her church paid the rest. And she got to see the doctor needed. But I'm thinking to myself, I didn't want to stress my sister. I'm like, I can't believe that you would have to go through this to get a medication that you need to live from a doctor.
And this was a cancer med at that point?
It was, yes.
And she had already suffered the amputations?
Yes, the amputation. She was already without legs. And,
so in a very compromised position.
Yes, and her husband had to quit his job to take care of her, so that made things worse. He was a very hard-working man, carpenter, fisherman. I give him a lot of respect. He really worked hard to take care of my sister. She had a very loving church, a lot of great people around her, and her children, and her husband. And
what was the kind of cancer?
Brain cancer. And also she developed a stomach cancer.
Wow.
So she was fighting, it was horrible.
Yeah.
I'm sure other people probably dealt with that. Just the pain and suffering one goes through.
Suffering faced by many families in the cycles of life. The moral question and the fiscal question is, how do we respond? Boston University's Jacob Bohr.
These are choices that we make as a society in terms of the funding levels that we put to these programs and whether we want to make them accessible. And you saw this with Medicaid expansion, and you saw this with the ways that different states approached the way that they made Medicaid available to people or not, in terms of the way that they advertised, in terms of the enrollment periods, in terms of the extent to which they had to document various things. And so the complexity is a barrier, but the extent of that barrier, how high that barrier is a choice. And it's a choice about, fundamentally, it's a choice about what we feel like we owe each other in the society that we want to live in.
Listening to Humankind. I'm David Freudberg. Studio recording by Doug Sugarts. Editorial assistance from Miles Blackwood Robinson, Kathy Graham, and Ken Rogers. Webmaster Brian K. Johnson. Special thanks to David Cruz and Tony Buck. Our program is presented by Human Media.
To purchase a CD copy of this program, please call 1-800-5-LISTEN. That's 1-800-5-LISTEN. Or visit our website, where you can also obtain an audio download of this and our other programs and can hear selected episodes free. You can access free written materials related to this program as well. Our web address is humanmedia.org. Again, if you'd like to purchase a CD copy of Humankind by phone, please call 1-800-5-LISTEN, and our web address is humanmedia.org.
And you can subscribe to our free weekly podcast, Humankind, on Public Radio, available at Apple Podcasts and elsewhere. This segment, Part 1 of Health Inequality, is Humankind Program number 268.
The executive producer is David Freudberg. This is Humankind.
To hear more episodes of Humankind, you can subscribe to our free podcast on iTunes, Stitcher, or your preferred podcast player. A new episode each week. The podcast title is Humankind on Public Radio. And if you enjoy this program, be sure to leave us a kind review at iTunes and Stitcher. If you want to support the program, please visit humanmedia.org. And at the top of the homepage, click on How You Can Help. Again, our web address is humanmedia.org. Thanks.
Hi, I'm David Freudberg, host of Humankind, and I love my work, the opportunity to talk with remarkably enlightened people about things that really matter to all of us. And honestly, the most fun I have is when I hear from listeners I've never met, often from places I've never visited, who've been touched by our Humankind program. The grants we get from the funders you hear named on our program simply don't cover all our expenses. And if you like what you hear, we're asking for your help so we can keep the program and this podcast going. Please visit humanmedia.org, and at the top of the homepage, click on How You Can Help. Thanks. Humankind is produced in association with WGBH Boston and supported by the Humankind Program Fund.
It's bad enough that you're fighting to stay healthy or stay alive, that you now have the stress of, oh my God, how am I going to pay my bills? How do I get my medications? To me, that is very stressful.
Adding financial pressure to the strain and stress of illness. You're listening to Health Inequality, a Humankind special. I'm David Freudberg. According to recent Census Bureau findings, about 15 million American children are being raised in families who live below the poverty level. And almost 8 million adults are counted as the working poor, people who are employed full or part-time in low-paying jobs. Sometimes they work multiple jobs to make ends meet. And these are the folks who seek health care here at Bellevue Hospital in Manhattan. Physician Dave Chokshi.
The patients whom I take care of are poor and working class people. They are taxi drivers in New York City. They're housekeepers, restaurant workers. And for many of them, coming in to see me in the clinic often means giving up a few hours or even half a day of wages. And when you're living paycheck to paycheck, taking out a few hours, even if you have that luxury, if you have a supervisor who will allow you to do that, often means the difference between having means that can get you to the end of the month or not.
And that's just getting in the door to see the doctor, let alone the challenge of paying for health care, at a time when premiums, co-pays, and deductibles continue to rise, and when some 30 million Americans still lack health insurance.
In the wealthiest country in the world, the fact that we cannot say simple things like all children will have a right to high-quality health care, to respect their dignity and their future opportunity in life, I think it's unconscionable. And there are so many other groups for whom that is true. We still have many gaps when it comes to taking care of elderly people in the United States. We have elderly people who are homeless, veterans, who go without access to care despite a very well-functioning VA in many ways. There are these various groups whom we should be able to say in this day and age that the opportunity for living one's life with dignity through access to the basic human needs like healthcare, like housing, like nutritious food is still not adequate.
So these people continue to fall through the cracks.
Yes, unfortunately, it's still too common.
a trend closely monitored by Ellen Lawton, an attorney who co-directs the National Center for Medical Legal Partnership. It's based at George Washington University in D.C.
Being poor in America is a very complicated and time-consuming activity.
Time-consuming to be poor.
Absolutely, because of the intersecting regulatory institutions that are supposed to help and support you if you find yourself without an income and with a family to support. But they're complicated to navigate.
And even those of us who have insurance sometimes butt our heads against the confusing instructions, the long lines, and the mind-numbing runaround from automated phone systems that assure us our call is very important to them.
Who among us hasn't thought about the IRS and trying to get a question answered or being fearful of submitting documentation for a range of different reasons? And that's something that we demand of low-income people in order to be eligible, quote unquote, for different services and supports so that, for example, a low-income mom can access women, infant, and children nutritional services, right? And then SNAP benefits, Federal Nutrition Assistance Program, a housing subsidy that you may be eligible for because of your recent experience as a veteran, as a victim of domestic violence, any number of different reasons that you may be in a category of special need also comes with, and appropriately so, obligations and responsibilities, but those actually can turn quickly into barriers and denials of service because you haven't complied with the requirements.
Here again is Rob Lawrence in Gloucester, Massachusetts, age 55. He recently suffered an injury affecting his shoulder, back, and knee. When we met, he'd been out of work for about 3 months.
I've always done overtime every job I've ever had. I was hard worker. And, being out of work is depressing enough, and then have to dealing with how am I financially going to get by, the insurance issues, which thank God straighten out now. But as you're going through the process, it's very hard and very stressful.
Rob works in the medical field and was taking care of disabled clients, some with brain injuries, in a group home nearby. Until his own injury, he was assigned 4 clients.
I love working with the clients. I love doing the best I could to help them. And through the years, I've worked there in nursing homes and hospitals, sometimes 2 jobs at once. And most recently, last 4 years, disabilities and brain injury, which I'm very happy to be involved in. And
happy to be involved because
it's just great to be able to have the knowledge and be able to help the clients and be able to understand with the experience I have, being able to understand their wants and needs and being able to provide that for them.
And was that full time for you?
It was full time.
So being out of work due to the injury is a hardship?
It really is. I mean, I had good health insurance, good dental, and when you leave a job, if you have, say, vacation time, and so on, sick time, once you use that up, you end up paying for your own insurance, and it's a lot. It can sometimes be a lot more than that. Like I have to send a check to the insurance company myself to pay for the insurance, but I did have a spell where I had some medications because it didn't kick in right away that went from a $15 copay to some of them being $50 or more to get my medications that I needed.
And for Rob, dealing with financial complications just adds to the burden of coping with physical pain and new limitations from his original injury.
I would say I've definitely lost a little sleep over the stress at times, yes.
Does it cause you to worry a lot or feel anxious?
It did when I was worried about, how am I going to get this covered? If I lose my dental, I noticed not to have dental insurance. I had 4 roots pulled and some work done in my mouth aside from that. And
When was that?
A couple months ago.
So after the accident?
Yes. And that was over a few $100s out of my pocket for all the dental work.
Dental bills can add up.
They can. You're in pain. You have to get it done. And I feel bad for those people. You know, there's a lot of jobs that don't offer dental coverage. And my heart goes out to them because I can't imagine the pain, the tooth pain, without having that insurance, what they go through.
And that's just part of the healthcare obstacle course, often facing people who are out of work or the working poor who don't have gold-plated medical plans. Ellen Lawton of the Medical Legal Partnership.
Low-income Americans are working in jobs that may call for much more physical labor. They're stressful and difficult jobs, for example, home health aides, people in the trades. I'm thinking about people who are using their bodies much more so in their work. And so that creates also an additional risk in terms of your health and well-being.
And the risks for this population are not confined to on-the-job hazards. They're also at home, especially for people in many of our big cities, for whom the costs of housing add considerable strain and impose rigid constraints on where you live.
And so you put that together with the choice and availability of healthy and safe housing, and what you've got is any number of different risks that people are exposed to, whether inside the home, where there are conditions that may create health risks, for example, mold that creates risks for asthma, and conditions that landlords are not ready to ameliorate or willing to ameliorate, that stairs, for example, that have not been fixed, that are creating hazards and risks for people who live there. All of those types of environmental situations that are going to then play out on the bodies of people who are living in those homes, people who are living in those communities and working in jobs where the risk and safety are not at a premium.
It's in neighborhoods where they may confront violence in a way that challenges their ability to live safely. How do you exercise in a neighborhood where you feel like your security is under threat? Similarly, I think about the threat of eviction for so many of the patients whom I take care of. When you're living paycheck to paycheck, this is a reality for you. And so how do you focus on anything else in life when around the corner, a week or two down the road, you may have to confront the threat of not having a roof over your son or your daughter's head? And so you can understand, I think, very easily how those things kind of get under the skin and affect one's health.
We're examining the many ways that living in poverty can affect a person's stress level and may impact their personal health. You're listening to Humankind. I'm David Freudberg. For more information on this segment, Part 2 of Health Inequality, to obtain audio downloads or CDs, please visit humanmedia.org. Even under the care of hard-working medical professionals, a patient's trip to the hospital is rarely pleasant. That was the experience recently for Reverend Bonita Grubbs. She's executive director of Christian Community Action, an interfaith center serving families in crisis around New Haven, Connecticut. One weekend, Reverend Grubbs started to experience severe stomach pains, but her doctor was unavailable to treat her.
She said the best thing for you to do is to go to the emergency room, which I did. And let's just say it was a zoo. There were all kinds of people in there. And, it's like, so what is happening to me? I don't quite understand. And so I, waited until I was seen, but it was scary for me because I didn't know what was going on. I was around all these individuals who had other challenges, and how do you actually get to the place where you are receiving care? And my stomach was hurting and doubling over in pain, and then finally I get to a bed, and then I get to go home after a period of diagnosis. And then the next thing that happened was you need to see this kind of specialist because you have that kind of problem. And it was a weekend. So by the time my own doctor got back, she said, "What happened to you?" And I said, "I have no idea." But because I have health care and because I have good health care, I was able to receive the kind of treatment. But imagine if I didn't have that connection with the doctor. Imagine what kind of fear there might be, and there would likely be, when you're in a place that's, lots of people in different places from different, communities in and around New Haven. And you're concerned about the pain that you feel and the challenges that presents for you, and are there people around to be supportive, that kind of thing. I mean, my brother actually was there to help and to be supportive, and so I had someone, who I could actually seek and get comfort from, but that's not always possible.
Bonita Grubbs has the benefits that go with a middle-class salary. In addition to her clergy training, she earned a degree in public health from Yale. But if our medical system can be hard to navigate for anyone in an emergency situation, things are tougher for someone dealing with health challenges while living on the streets in Connecticut. Here's Lauren Taylor, co-author of The American Healthcare Paradox.
Joe was a diabetic, and he was also homeless, and so he lived in the back of a boarded-up house. And he didn't have a refrigerator. And so even though he had a prescription for insulin, there was no place for him to keep that insulin and be taking it regularly. So he was a fairly out-of-control diabetic. And to make matters worse, he lived in kind of a swampy area where, in order to get, without being seen, from the back of this boarded-up house where he was not supposed to be living out to kind of the street, he had to wade through kind of a wet, boggy area. And so Joe, we came to know Joe, my co-author Betsy and I, through a case manager who worked at the local hospital. And she told a story of Joe as being a frequent flyer. And a frequent flyer is the term used by medical staff who see the same people often. And often can mean a couple times a year, it can mean once a month. And she was seeing Joe very regularly. And the reason she was seeing Joe so regularly was because he was having a lot of pain in his feet, and he would come in. And he'd come in through the emergency department. And in the past year, before we spoke to this case manager, she said he had already had a few toes that needed to be amputated, and it was really looking like he may need a below-the-knee amputation in the not-too-distant future. This was going to require, of course, a ton of medical costs, but then especially if he wound up with a below-the-knee amputation, he was going to wind up needing a wheelchair and some additional things to just navigate around his daily life. And this was going to be costs that I would say are borne by us all, because whether it was uncompensated care, meaning no insurance was paying for him, or Medicaid was going to pay for it, that all comes out through kind of general revenue taxes or prices that we pay for health care. So we all do bear that cost. And the real kind of profundity of the story was, at some point she said, we have just poured so much into this gentleman by way of medical expenses to try and keep him propped up. But of course, he's in pain. No one likes to be in and out of the hospital, and no one likes to be suffering progressively more disabling surgeries. And no one ever stopped to think to buy him a different pair of shoes. And a different pair of shoes, while it may not have solved everything, would have been a $50 investment that definitely could have changed the trajectory of that disease pattern, to say nothing about whether someone might have been able to get him into a place of housing where he could have a stable refrigeration system and actually get his insulin going on a regular basis and his blood sugar under control. And so I think the story is just reflective of how we think about and how we prioritize types of spending in this country. For a long time, it has seemed that we're perfectly happy spending exorbitant amounts of money on medical care. And the spending on medical care has been virtually unchecked from a societal perspective. It's just grown and grown and grown. And yet, when it comes to the point of care and trying to get people these really basic social supports that would enable them to be healthy, we just don't seem to have the kind of political wherewithal to do it.
Since the advent of Social Security in the 1930s and the Great Society programs established in the 1960s, it may seem that older Americans or those who become disabled or fall onto hard times are amply protected by our social safety net, that people in need are not coldly left to fend for themselves. Lauren Taylor.
The patchwork of social service programs that we have in this country is just that. It's patchy. And the eligibility requirements for one don't match the eligibility requirements for another. And so navigating that can be extraordinarily complex.
And for people in a vulnerable position, often with few resources and sometimes limited education, working through the maze of public assistance can be confounding on the best of days.
The list that you get put on to wait for, let's say, public housing, let's just take in Boston as an example, currently has something like 7,000 to 8,000 people on it. And so you fall through the crack and you go to the back of that line. And then you wait in that line, essentially. And the line for housing, just like the line for a lot of other social services, is long, but also winds up prioritizing what we call high cost, high need. So the most complex cases and the ones that are posing the potential to cost the state or the federal government the most money. And so you can kind of patiently wait your turn for a long time and not get to the front of that line and be offered a public housing or an affordable housing unit until you've become a walking catastrophe, until you have a documented serious mental illness, you have some kind of physical disability, and you're still without a home. Maybe it's years later. And so this happens again and again in our social services. We want to prioritize the people who need them most, but if you're someone who just happens to fall through the crack on Tuesday, it's a long time until you're the person who needs it most. And so our system waits until people become really, really, really disabled and incapable of serving themselves in order to then offer kind of what's supposed to be a leg back up and back into a job and a functioning home and a life of stability. But when you design a system that way, you know, we're not talking about a net that kind of catches people and catapults them right back to where they were. We're talking about a net that like ensnares people in this really complicated bureaucracy that can take years to get out of, and is really probably not in anyone's best interest.
Typically people already in a vulnerable position. Dr. Dave Chokshi in New York.
Every single dollar goes toward basic human necessities: food, housing, childcare, things that if you are more affluent, you take for granted in many cases, that those things will be covered and that you have enough income to spend on health care.
So under those circumstances, do you find your patients sometimes skipping medical appointments or avoiding making medical appointments at all?
Certainly. I think about a patient of mine whom we diagnosed with diabetes, which had clearly been longstanding. He had probably suffered from diabetes for 10 or 15 years prior to seeing me. And so even though we were able to take good care of him, we brought his blood sugar level under control. He also had high blood pressure, and we were able to get that under control. But unfortunately, because he had had such long-standing diabetes, he had a condition that affected his eyes, known as retinopathy, and it had progressed quite far by the time that we saw him. And so now he is legally blind because of that effect of diabetes on his eyesight. So in many cases, we see people whom we could have prevented complications for had they made it to us earlier.
But for numerous reasons, patients needing to be seen by a doctor or nurse may resist coming to the hospital or clinic. They may balk at the complicated rules or fear they'll be socked with an invoice. And for some reluctant patients, there's another reason. Physician Dave Chokshi.
It may be some distrust of the healthcare system. Perhaps they have encountered discrimination in the past, or perhaps there is some reason that hospitals and clinics are not welcome places for them to go. And in still other cases, and I think about this particularly in the current political environment in the United States, where we have a growing anti-immigrant rhetoric, which keeps people away out of fear, because the idea that seeking care might be linked in some way to their immigration status and threatens again, their ability to live in their community in the United States. And
do healthcare providers interact with the immigration system?
No, and I should make it very clear that certainly in our system, New York City Health and Hospitals, we do not ask about immigration status, and everyone is welcome, including undocumented immigrants who call New York City home.
Is that pretty much the case across the country?
It is, and I think most people who have gotten into healthcare, whether you're a doctor or a nurse or another clinician, you abide by the same Hippocratic oath that all physicians take, which is to do no harm.
But nevertheless, there's a portion of patients who don't show up for fear of getting their immigration status yanked.
And often that means it keeps them away until there is a health catastrophe, that requires that they have to come in to the emergency room or get admitted to the hospital.
In other cases, people are eager to get help, but may find it difficult to work their way through the system. Ellen Lawton of the Medical Legal Partnership.
A pediatrician referred a mom to me, and Layla was Spanish-speaking, and I am also a Spanish speaker. And so the reason that she had been referred to me was because she had been eligible for some extra support from the state for a temporary period of time because she had 3 small children and had to take out a restraining order against her husband and had been a victim of a violent assault in front of the children. And so she had reported it, and he had left the home, and she was left without income because he had been supporting her. And so was helpfully directed by the hospital case manager to apply for this special time-limited benefits to assist people who are in that kind of situation to hopefully move into safety. And she was having problems accessing those benefits and was really having a hard time with the bureaucracy. And they had denied her application, and she was worried she was going to be evicted from her apartment. And she, again, had 3 small kids under the age of 5 at the time and was terrified. And so I was able to work with her, go to the office where she had applied for these benefits and act as her ally and advocate and kind of straighten it out, actually fairly rapidly. And as a result, she was able to rely on that income for a period of time until she got a licensure to do childcare in a daycare center in her neighborhood.
Listening to Humankind. I'm David Freudberg. Studio recording by Doug Sugars. Editorial assistance from Miles Blackwood Robinson, Kathy Graham, and Ken Rogers. Webmaster Brian K. Johnson. Special thanks to Tony Buck, David Cruz and the Open Door Pantry in Gloucester, Massachusetts. Our program is presented by Human Media.
To purchase a CD copy of this program, please call 1-800-5LISTEN. That's 1-800-5LISTEN. Or visit our website, where you can also obtain an audio download of this and our other programs and can hear selected episodes free. You can access free written materials related to this program as well. Our web address is humanmedia.org. Again, if you'd like to purchase a CD copy of Humankind by phone, please call 1-800-5LISTEN, and our web address is humanmedia.org.
And you can subscribe to our free weekly podcast, Humankind, on Public Radio, available at Apple Podcasts and elsewhere. This segment, Part 2 of Health Inequality, is Humankind Program number 269.
The executive producer is David Freudberg. This is Humankind.
To hear more episodes of Humankind, you can subscribe to our free podcast on iTunes, Stitcher, or your preferred podcast player. A new episode each week. The podcast title is Humankind on Public Radio. And if you enjoy this program, be sure to leave us a kind review at iTunes and Stitcher. If you want to support the program, please visit humanmedia.org. And at the top of the homepage, click on How You Can Help. Again, our web address is humanmedia.org. Thanks.